Well, good evening, everyone, and welcome to all of you from all over the world. This is really exciting. And tonight, our Evenings with Genetics webinar will be on the topic of Ehlers-Danlos Syndrome, Hypermobility Type. I'm Susan Fernbach, and this webinar series is sponsored by the Department of Molecular and Human Genetics at Baylor College of Medicine. We have two fantastic speakers tonight, Dr. Shweta Dhar and Lara Bloom, and I'm very pleased to introduce them. We ask that everyone mute their devices so that we can have questions at the end. The questions are going to be moderated by Andy Lewis, a genetic counselor from the Texas Children's Genetics Clinic. And this Thursday will be Genetic Counselor Awareness Day, as you can see on the slide. So Andy, if you want to wave your hand, that would be great. So let me tell you a little bit about our speakers. And just to let you know, we are recording, and that's why we had wanted to have the questions at the end. Our first speaker is Dr. Shweta Dhar. She's an associate professor of molecular and human genetics, and she's the director of the Adult Genetics Services at Baylor College of Medicine. In addition, she's the chief of genetics at the Michael E. DeBakey Veterans Administration Medical Center in Houston, and she's board certified in both internal medicine and medical genetics. Dr. Dhar specializes in genetic conditions in the adult population, including Ehlers-Danlos Syndrome, Marfan Syndrome, neurofibromatosis, familial cancer syndromes, among others. She has established an Ehlers-Danlos Syndrome clinic at Baylor College of Medicine and has been involved in the care of heritable connective tissue disorders for the past decade. Besides many peer-reviewed publications, Dr. Dhar has also recently authored a textbook chapter on heritable connective tissue disorders in Rudolph's Pediatrics. Our second speaker will be Lara Bloom, and she is the president and CEO of the Ehlers-Danlos Society and responsible for globally raising awareness of the rare, chronic, and invisible diseases, specializing in the Ehlers-Danlos Syndrome, hypermobility spectrum disorders, and related disorders. Before joining the Ehlers-Danlos Society, she ran the EDS UK from 2010 to 2015 and played a key role in the recent international effort to reclassify EDS and create management and care guidelines. And she's an author on the publication that resulted from that and was published in 2017 in the American Journal of Medical Genetics. She also serves on the steering committee of the International Consortium for EDS and Related Disorders. And in March of this year, Lara was appointed a professor of patient engagement and global collaboration at Penn State College of Medicine in the US. And she will be speaking with us tonight from London. So she's on a much different time zone and maybe quite tired by the Q&A, but we really appreciate very much both of our speakers. So from your homes, please give a warm round of applause from our first speaker, Dr. Shweta Dhar.
Thank you for giving me this opportunity to talk today to you all. I will be covering the topic on advances in the care of people with Ehlers-Danlos Syndrome, and particularly discuss about the common EDS type, which is the hypermobile type. So we'll continue with this topic on covering the types of EDS, the genetics of EDS, and then I'll finish off with some management guidelines. So what is EDS, or Ehlers-Danlos Syndrome? This is a family of disorders, which is a group of related conditions that share a common decrease in the tensile strength and integrity of the skin, joints, and other connective tissues. So we all know that the tissue underlying our skin, around our blood vessels, is what we call the connective tissue. And when this connective tissue gets compromised because of mutations in certain collagen genes, then that leads to this condition that we all are familiar with, which is called EDS, or Ehlers-Danlos. But there are many different types of EDS, and this word was first coined or first described by Edward Ehlers and Henry Danlos, who described sort of this skin elasticity back in the 1900s. It was not until 40 years later that the word Ehlers Danlos Syndrome was coined. And then several years later in Berlin, they basically identified 11 subtypes at which, and these were at that time numbered as type 1, type 2, type 3, and so on. In 1998, in Villefranche, this nosology was changed to include 6 subtypes and not kind of call them as type 1 and type 2 numbers, but instead call them by their actual descriptive names. So for example, type 3 was then changed to hypermobile EDS. And then finally, in 2017, the EDS International Consortium got together, and now we have 13 different subtypes of EDS. And these are molecularly based. We now know the genes for many of these EDS subtypes. And so this is how the new subtypes have been determined. Here's a table kind of showing you the different classifications for the different subtypes. As you can see, our classic one is the classical, which was earlier the type 1 and type 2. And this is the one that has a lot of skin elasticity, widened scars. The other common one that we are all familiar with is the vascular type, or the VEDS. And this is the one that we worry about the most, the one that has the most serious complications, such as hollow organ and blood vessel ruptures. And then, of course, the most common type of all of these subtypes is the hypermobile type, or the type 3 that was originally known. As you can see in the last column here, I have all the genes listed, but we still do not know the gene that is associated with hypermobile type of EDS. There are many other subtypes, and most of these subtypes are determined based on their prominent feature. And as you can see, there's sort of overlapping features across the different subtypes. So while you may have skin hyperextensibility in the musculocontractural or in classical EDS and some of the hypermobile type of EDS, we go by the most prominent feature to kind of determine that subtype. And of course, we then confirm the diagnosis if we can through genetic testing. Besides the 3 that I mentioned, the rest of the EDS subtypes are fairly rare. So let's just kind of briefly go over vascular and classical before we delve into more details about hypermobile type of EDS. Now, vascular EDS, I know, is the most concerning, it is the most serious and can potentially be fatal. Most of the EDS, out of most of the EDS, about 5 to 10% are vascular EDS. They do have some characteristic facial features, as you can see here, more of kind of the sunken jaws. It's called acrogelia, or more kind of like an older person features. They do have very thin and translucent skin, as you can see here in the hand. You can actually see all the blood vessels in this lady's hand, which are these highly visible subcutaneous vessels. They can have a lot of bruising and hematomas, as you can see in the leg here, and they don't even realize it. They may just be walking, or they slightly tap on something, and because the skin is so fragile, they tend to have all these blood clots underneath. Typically, people with vascular EDS do not have sort of the super stretchy skin that we see in other types of EDS. So the skin hyperelasticity is fairly low. Classical EDS, which was the type 1 and 2 originally called, is distinguished by its skin hyperextensibility. So it has this super stretchy skin that we know. And because of that, the skin doesn't get apposed very well after there's a cut or a scar. And that's why you have these sort of widened looking atrophic scars, which basically means that the tissue is fragile and it's not able to sort of appose properly. Joint hypermobility also can be seen with classical EDS. It can affect both large and small joints, and is usually noted when a child starts to walk. And then, of course, many times they do have a positive family history. But remember, the most important sort of characteristic with classical EDS is the super stretchy skin that these individuals have. Here are some pictures. So you can see here in the hand, if you pull kind of the skin, and usually we try to pull it over here, and you kind of pull the skin up, and if you can feel the stretchiness of the skin. The scar on the knee, as shown in this picture, also shows sort of a wide-looking, thin, papery scar. And so these wounds tend to gape or split. They have poor wound healing because the skin has lost its elasticity. Let's talk about hypermobile EDS in some detail. I imagine most of you are familiar with the hypermobile EDS, and we call it hypermobile because the most prominent feature of this condition is the joint hypermobility. There are many overlapping symptoms with the other subtypes of EDS, and people who don't kind of meet the criteria, we also put them in this diagnostic criteria as hypermobility spectrum disorder. You can see in 40% of school-age children, you can see generalized hypermobility, but not everybody has hypermobile EDS. Children tend to be hypermobile, but as everyone grows older, the joint hypermobility should go back to its sort of normal range of motion. But if it kind of persists, if the hypermobility persists, that's when we start thinking about hypermobility spectrum disorder or hypermobile EDS. Baton score is the most widely accepted system for objective quantification of joint hypermobility. As you all may have seen, you kind of try to touch your thumb to your forearm. You try to push your little finger all the way back, your elbow extension, knee extensions, and then kind of touching the floor with the palms of your hands. So if you can meet a score of 5 or greater than 5 out of 9, then that is our objective measure of joint hypermobility. These are the criteria that were established in 2017. And you need to meet all 3 of these criteria in order to get the diagnosis of hypermobile EDS. And these were made because earlier the criteria were fairly loose. It was very challenging to make the diagnosis because there are so many organ systems involved that it became kind of challenging to decide when to give the diagnosis of hypermobile EDS. More importantly, because of this challenge, for research studies, we did not have very clean sort of clinical cohorts of patients. And so I think that in 2017, when the group of experts got together to determine these criteria, the main that could sort of meet these criteria, and then in those we would continue to do genetic testing and research studies so that when we find the gene or genes involved in hypermobile EDS, we kind of have a proper clinical phenotype, means your joint hypermobility. So as I mentioned, the Baton score of 5 or more. There are sort of different scores depending upon the age, but typically you do need to meet the Baton score to meet criterion 1. For criterion 2, there are sort of features A, B, and C. In the feature A, you have about 12 different manifestations, including sort of stretch marks, history of prolapse, and skin hyperelasticity, dental problems. You kind of include all of those manifestations in feature A. You need 5 out of 12. Feature B is positive family history, which means 1 or more first-degree relatives, which means either your brothers or sisters, or your children or your parents. Somebody has to have met the criteria for hypermobile EDS independently. And then that would count towards your positive family history. And then feature C are must 3 months, and sort of having that joint instability. And then criterion 3 is that all these prerequisites must be met, which means that you should have ruled out other types of EDS or other conditions that could give rise to these features. So for example, autoimmune conditions, a lot of times people have diagnosis of rheumatoid arthritis or lupus or something autoimmune. If those have been ruled out that do not explain your features, then we can say you've met criterion 3. Many times you can't really tell. Like I said, there's so much overlap between the symptoms of the different types of EDS. If you can't tell whether this could be potentially vascular or classical, until you do genetic testing, you can't really rule out the other types. And so once you've kind of ensured that there's no other explanation for that individual's sort of symptoms, then we say that you've met criterion 3. And remember, you need to meet all 3 of these in order to get the clinical diagnosis of hypermobile EDS. So kind of talking about genetics, let's talk about what genes are involved. Now, I typically get this question all the time that if I have, hypermobile EDS, will my child get vascular EDS? And I think that, usually only one type of EDS will run in the family. So we expect mutations in the same gene to go from one individual to their children. Of course, anything is possible, but our diagnosis is established by clinical exam, and this is confirmed by molecular diagnosis. Remember, I said there's no gene for hypermobile EDS, so sometimes what we have to do is rule out other diagnoses in order to rule in the hypermobile type of EDS. I have kind of listed the genes for the classical and the vascular because these are the other two common types that we face in our clinics. And so the classical type of EDS is associated with the COL5A1 and the COL5A2 gene. And 50% of the times, this condition is de novo, which means that you won't have a family history and you would be the first person in the family to get classical EDS. But once you have it, it's 50% chance that each of your children would also get it. The hypermobile type also tends to have the same 50% chance of being inherited. And then we don't know if there are people who get hypermobile without any family history. Until we get the gene, it is difficult to kind of know all of this for sure. And then the vascular type is associated with COL3A1 gene. And again, it's 50% times not found in a parent, which means it's de novo or that individual presents it the first time in the family. This is what we call autosomal dominant inheritance, which means that 50% chance that you would pass on that gene to each one of your children. So we have two copies of every gene. One copy we get from mom, one copy we get from dad. And if one of those copies has a mutation or a variant that causes disease, then that's the one that's going to cause EDS or Ehlers-Danlos syndromes. Most of the subtypes are dominant in inheritance, but there are several that are also recessive, which means that you need both your copies to be altered in order to get the disease. Let's talk about the single gene testing or the genetic testing for EDS. So many years ago, we used to do kind of single gene testing, which means that if we suspected vascular EDS, we would just test for the COL3A1 gene. In the past 5 years or so, with all the technology sort of advances, we now do panel-based testing, which means that we run sort of several different genes at the same time. And this has been possible because of all these next generation sequencing technologies that we have. And so we can sort of, if you want to do testing for EDS subtypes, you can just do an EDS panel, for example. And usually these EDS panels have about 15 or so genes on them. When we do this test, the possibilities are that you will find a mutation, which we now call a pathogenic variant, so which means it's positive. We may find something what we call as likely pathogenic, which means that it's kind of, we think it's disease causing. We don't have all the evidence, but for all practical purposes, it is disease causing. Similarly, on the other end of the spectrum, we have what we call benign, which means it's negative. You all have variants that don't do anything, don't cause any disease, and those are called benign variants. And labs will not report those variants. And sometimes we have likely benign, which means, again, we have all the evidence, but not all the way to push it to benign. The one category of results that we worry about is called the uncertain significance, or the variant of uncertain significance, or VUS. When that happens, it's because it's smack in the middle. So we now don't know whether this is a variant that's going to kind of be on the pathogenic side and cause disease, or is it a variant that's going to eventually be benign and not really do anything for disease causation? And because our information is limited at the time that this report is resulted, we kind of have to wait for time and see when more information becomes available, we decide what we want to do with this variant. Until then, based on the clinical findings, that's kind of where your physicians will help you sort of understand that you have a VUS, depending upon what gene it is, how relevant it is to your clinical history. We then decide whether we want to do something about it or not. So for example, if I did EDS testing on or panel testing on my patients, and I found that there is a COL3 variant of uncertain significance, which is the gene that causes vascular EDS. then I am concerned because yes, I know it's a VUS. I don't know whether it's going to be on the side of pathogenic or it's going to eventually become classified as benign. But until such time, what I'm going to do is actually err on the side of caution and do more instead of less. And so I would kind of make sure I do sort of screening for vascular aneurysms and dissections, just because I don't know where this result is going to eventually be classified as. So how do we use these genetic testing results? So let's say, our test is positive. I run the EDS panel and it's positive. So what does that mean? So depending upon which gene is abnormal, we will sort of make that diagnosis if it's a classical EDS or vascular EDS or any of the other subtypes. And then accordingly, we would do management for that particular subtype. If the genetic testing is negative, what does that mean? It means that we've ruled out all of the other causes of EDS. Remember, I said hypermobile EDS does not have a gene associated with it. So we go back to the 2017 clinical criteria. If they meet criterion 1, criterion 2, as well as criterion 3, so they've met all the clinical criteria, we've ruled out other types of EDS, then we can say that this confirms the diagnosis or clinical diagnosis of hypermobile EDS. And then if the genetic testing shows a variant of uncertain significance, as I just mentioned, the further management would be based on which genes are abnormal, the clinical features, and then we can give a provisional diagnosis of hypermobile EDS, depending upon how the presentation is for that patient. So with that sort of overview on how we make the diagnosis, let's talk about how do we manage EDS, because that's kind of the most important thing here, because we do want to improve quality of life. We do know that there are so many clinical features associated with hypermobile EDS, and there's many different organ systems involved. You can have your joints involved, which is sort of the prominent feature with your dislocations or subluxations, and that leads to that chronic pain, which is your POTS or your orthostatic hypotension, temperature intolerance. You can have problems with your teeth, particularly the jaw, your easy bruising and poor wound healing, not as bad as those who have classical EDS, but still there are skin problems. You can have headaches, or you can have your blurry vision because of problems with the eyes or the vision. A lot of people have mast cell activation syndrome with those increased allergies, sometimes increased infections as well. And then women also have issues with heavy menses and pelvic congestion and endometriosis. So as you can see, it's all over the body. There's so many different organ systems involved. So many different specialists might necessarily be involved as well. There are certain things we do for ongoing management. So we do look at the blood vessels, so the echocardiogram. There was a recent study that came out that showed that for the most part, the aorta or the blood vessels don't get enlarged in people with hypermobile EDS. And I would agree. In all my patients, I would say maybe less than 1% actually have anything in the aorta. But because it is a connective tissue disorder, because the risk is potentially there, it's always a good idea to initially screen for dilation of the blood vessels. And that's pretty much the main blood vessel coming out of the heart, which is the aorta. People with hypermobility tend to have low bone density. So we also do a DEXA scan, which is your regular bone density scan that we do in older individuals, particularly for screening for osteoporosis. But in case of hypermobile EDS, you would do a DEXA actually in younger adults as well, because if it is low, you can do something about it. You can give vitamin D, you can give calcium, or even other agents that can kind of help improve bone density, because you don't want to add fractures as one more sort of comorbidity in EDS. You can get an eye exam as well, and then we do physical therapy, which is what I'll describe in the next few slides, and then pain control as well. There are many problems with management, as you may have encountered. Those affected with EDS have the longest delay in diagnosis and usually request consultation of up to 20 specialists before obtaining the correct diagnosis. And so this was a study that kind of looked at 16 major rare diseases, and this is what was found. And you all might, some of you or many of you might agree with that it takes time before you get to the right provider to get sort of the right management for your problems. This leads to obviously a lot of time and expense. Sometimes you get investigated for lots of different things just because somebody's not able to put everything together and give you the diagnosis of EDS. You can get wrong treatments. A lot of times I have patients who've got every rheumatological treatment, including steroids, including all of the other sort of, higher potency drugs that they use. And it doesn't help because they may not have a rheumatological condition. And if it's EDS, maybe it's not going to work, which then delays your appropriate treatments. And of course, it worsens your disease state and sort of worsens your quality of life. So we do understand that there are problems with management. This is a picture of how pain has its different manifestations. As you can see, there's different reasons for pain, including your injuries and dislocations. All of that can be painful. The muscles around your loose joints have to work a lot because they're trying to support the joints. And so the muscles get sore, they go into spasm, they hurt. And then you're not able to do exercise, your muscles get detoned, they hurt even more. So you're constantly in that cycle. And of course, you have associated comorbidities with your bladder, GI, psychological, neurological, and cardiovascular issues. So all of this together becomes fairly overwhelming, leading to sort of pain-related disability. So how do we manage that? We can give medications. So your simple Tylenol or Brufen or any of those Advil, Aleve, all those non-steroidal anti-inflammatories, they can help the mild to moderate pain. They may not necessarily completely cure the pain. And what I usually tell my patients is that you kind of want to cure 5% of 10 different symptoms, which will still give you a larger effect than kind of taking one symptom and completely curing it 100%. Because one, you're not going to be able to cure a symptom 100%. But two, you will see a far more reaching effect if you kind of correct the different symptoms little by little. And they actually kind of all feed into each other, and that overall will give you a lot of relief. Sometimes you do get a short course of steroids if you need to. If you've kind of dislocated and caused injury to the joint and caused inflammation, then yes, you do need steroids. That might help. With muscle relaxants, I have many patients who are muscle relaxants sort of once a day, every day, or twice a day, and I tell them that shouldn't be used in that manner. Because if you think about this, if you relax the muscles, they are not going to be able to support your loose joints. And so if you relax them so much, yes, the spasm will go away, but then you'll end up with having worked them even more and then even more pain. I understand that sometimes you do need to take them because there's just so much cramping and pain, but that's why I say use them sparingly. Epsom salt baths, which contain magnesium, tends to help a lot of people. So that's something that can be done. Coenzyme Q10 and carnitine can help with the sort of the muscle. And then if you have sort of neuropathies, then your pregabalin and gabapentin can help. And then antidepressants also can help with the psychological comorbidities, also help with some of the pain. And sometimes you may need more than one agent to help with the pain. But along with those medications, you also want to do physical therapy. And that is the mainstay of treatment. When I see patients, I spend a lot of time kind of explaining sort of the physical therapy reasons behind, in management of EDS. You kind of want to make the muscles stronger. If the muscles are strong, they can support the loose joints. And and you will see the change in lifestyle, as you go, when you have sort of built up more muscle mass. And as you do more exercise, you will start feeling better. And the more better you feel, the more exercise you can do, then you kind of get, so it's kind of that cycle again. It's hard, but that's kind of the mainstay of treatment. And while you're doing that, you can take pain management, you can do splints, you can do braces, you can do massage therapies, whatever you need to support the joints so that you can actually get your muscles back in shape. Sometimes cognitive behavioral therapy also helps. And then sometimes surgery is required. So surgery is not a contraindication with hypermobile EDS. If you do need it in highly selected cases, if kind of you failed all treatments, you failed all your trials with conservative management, then if you need surgery, you need surgery. And then there are other invasive therapies out there that can also be used. but it's best to kind of follow up with a pain management expert. There are non-pharmacological measures such as your, aqua therapy or heated pools. They really help. Gentle stretching, walking is a great exercise. It also helps with your bone density. Your splints, you can wear these, especially I have young adults who are kind of texting all the time or on their computers. And of course, nowadays with COVID, all of us are on our computers. You kind of want to support your loose joints and the fingers with these kind of splints. And so you kind of have these finger splints, which can be metal, plastic, whatever you choose, but they do really help. And of course, relaxation therapy, making sure you're sitting appropriately. If you're sitting at your desk, all those ergonomic features that you can have around in your work area or wherever you sit is always helpful. Dysautonomia or autonomic dysfunction, our involuntary nervous system tends to be slightly impaired. So you kind of want to avoid your triggers that causes those sort of dysautonomia, such as heat, prolonged standing or sitting, alcohol, and then you increase your fluid and salt intake. Compression stockings can be used, and then exercise also helps. So no lying down for more than 8 hours at a time, because then you can kind of make sure your feedback loop is exercised properly. And of course, if you need help from medications, you can sort of use some of these to reduce the heart rate, because most people have that, what is called POTS. So because your blood flow to the brain is slightly, it takes a little bit of time for that to happen. You tend to kind of feel a little lightheaded when you get up, let's say from a sitting position. So because the blood pressure falls, your heart rate has to go up, excuse me, in order to sort of get that blood to the brain. And so you can feel your palpitations. And so you want to reduce the heart rate and kind of sort of stabilize the blood pressure by using beta blockers. You can use midodrine, which is your alpha agonist. So it kind of does peripheral constriction of the blood vessels and increases the blood flow to the heart. Or you can increase blood volume by fludrocortisone as well, or Florinef. And different people can use sort of different combinations of these, but they are effective in helping with dysautonomia. GI symptoms, so that's our biggest challenge with hypermobile EDS. There are lots of functional GI disorders that seem to be associated, like your irritable bowel. Some people have constipation, alternating with diarrhea, bloating, abdominal pain. And the problem is that there are no well-validated management guidelines yet. So we do what we can. Trial and error in your diet. Some patients I have tell me they are allergic to broccoli. Some say they're allergic to cauliflower, Brussels sprout, there's different things. Gluten sensitivity is a big one. But overall, people say if they have sort of low FODMAP in their diet, that might help. Supplements can help to some degree as well, including high-dose vitamin C. That's up to 1,500 milligrams per day. And then kind of taking small meals at a time, and not, even though there's constipation, you don't want to bulk up too much at one time, because if you have too much bulk, your motility is already low, and then it's not going to be able to move fast enough. And then you kind of feel more heavy and, bloated and all of that. So don't take too much fiber at one time. I wanted to talk a little bit about fatigue. So the cause for fatigue in hypermobile EDS is because of the joint pain, because of the muscle soreness, but also because of the dysautonomia. And, all of us get fatigued at some point or the other. And so it receives little medical attention, but it does contribute significantly to the burden of disease. There's this overwhelming sense of tiredness. There's lack of energy, feeling of exhaustion. And if you have that, you really can't exercise, right? I mean, we tell you all the time to go exercise, do physical therapy, but if you're so tired, you don't want to get out of bed, then it's kind of not helping your case. It's not the same as muscle weakness. So fatigue is kind of different from what we call typically muscle weakness, but it does lead to disability and affects quality of life. And then this relates also because you have sleep disturbances, concentration problems, so that brain fog that can be seen with dysautonomia, the pain, all of that will lead to severe fatigue. And so you kind of want to change or try to treat all of those other symptoms little by little to help with the overall sort of sense of fatigue. You also have neuromuscular involvement. So your muscle weakness, for example, sometimes you can also rupture the muscles, which obviously leads to more pain. And it's not because people with EDS avoid exercise and, because they fear that they're going to dislocate, but it's because their muscles do sometimes get weak. And they have these sort of mixed myopathic neurogenic features when they do these muscle studies. But then when you do a muscle biopsy, it doesn't show anything. And so there's a lot of times an overlap between mitochondrial disorders and EDS. But most of the times, these are mitochondrial disorders are far more severe. You will have muscle biopsy changes and usually tend to be progressive and tend to be more earlier ages in onset than typically that we would see with hypermobile EDS. But it's just something to keep in mind. And then I kind of wanted to bring this EDS in the classroom. I think we do, I do have, I see only adults, so I do have a lot of parents who come with sort of young children who are, in college. And we do kind of talk about how do we create sort of an emergency plan? How do we create sort of certain accommodations if required? Because, for example, additional time for test taking or help with note taking, you kind of want to use your ergonomic pencils or pens. You want to avoid high impact weight bearing or contact sports, so things like that. So there's just some, and with children, like I said, there's their default, they tend to be hypermobile, but we do want to make sure if you have young children who are complaining all the time about pain, or you kind of see them dislocating, you kind of want to pay attention to it and seek evaluation if need be, because you want to kind of make sure that they get the right management earlier on. Medical IDs is always a good thing, especially for anybody with a chronic genetic disorder, because that kind of tells you, if you're in a position where you're not able to give information, you can actually have that on your card, which can kind of tell you what is the nature of the illness and if there's any complications, what needs to be done. That way, then, people know what to do. And with that, I thank you for the opportunity to talk today, and I will answer any questions that you may have. Thank you.
Thank you so much for the opportunity to come and speak to you all about the work we are doing at the Ehlers Danlos Society. So I thought I would just briefly cover the 4 pillars of our mission. And as you can see here, we focus all that we do on education, awareness, advocacy, and really the core of what we're doing is research. And it's been a really, really long time since there was an organization. In fact, there has never been an organization globally giving this kind of level of funding to research to try and answer these really critical questions. So it was really important to us that this was put in place. And you can see here that over the past just 2 years, since 2018, we have actually raised $3 million for research grants and studies related to EDS and HSD, which is something we're really, really proud of. And we really hope to continue that, even despite these incredibly challenging times that we're living in at the moment, because we know how important this is to progressing things forward. You can also see here how we've grown in that time. So back in 2015, we were what was then known as EDNF, which was the Ehlers Danlos National Foundation, and it was a US support group. And at that time, we decided we were going to relaunch as a global organization. And so since then, you can see the outreach that we've had from going from a US organization to an international one. On Facebook, in 2016, we had 25,000 followers. We've now got nearly 91,000, actually. That's gone up. In Twitter, we had 2,000 followers. We've now got almost 16,000. And Instagram, we didn't even have a platform. We had 0. And this year, we've got 37,500 followers. And on the website, we had on average 20,000 unique visitors a month in 2016. 2020, we have 367,000 unique visitors every month coming onto our website. And on Inspire, which is our forum, our message board, we had 4,000 people in 2016. And in this year, we've got nearly 86,000. So you can see just how many people are impacted by these conditions, by the comorbidities, and just how needed a global voice was. Something else that we have launched in August of 2018 now was the first ever EDS and HSD global registry. When we began, we thought, you know what, there's going to be so many people that want to join this. And, you know, in honesty, it was a slow start. But we went from having just 1,500 people in August 2018 to today having 10,500 people registered on there from all over the world. From all the different types of EDS and HSD. And it really is a very, very rich source of data. Largely, we've been using it for our own research study, HEDGE, which I'm going to talk about a little bit more. But we also really look forward to being more proactive with this and also launching an EDS and HSD global repository. And so that will be when you have had genetic testing elsewhere, either consumer testing or through a doctor, and you want to upload those results, that will also enable us to answer more questions and understand more through that genetic information as well as the phenotypic information that you put in through to the registry. So we're really excited to launch that hopefully next year. And I mentioned HEDGE. So HEDGE is a really pioneer and groundbreaking study, and it was ultimately to search for the genetic causes behind hypermobile EDS. We know there's 13 types of EDS, and HEDS is the only one which we do not know the marker for at this time. We were very, very lucky to have $2 million pledged to answering these questions. And we very quickly formed a group of international experts who came together and gave their opinion on the best way to do this. We have now enrolled about 450 people out of the 1,000 that we have, that is our goal. COVID-19 has, of course, put a spanner in the works for in-person enrollment. And so we've adapted and changed it, and we have launched a month or so ago the option to be virtually enrolled onto the study so that it wouldn't impact our time frame and our goal of trying to do the analysis for next year. So we hope to have enrolled our 1,000 people by the end of this year, hopefully, but it may go into Q1 of next year, and really start to answer these questions that surround this type of EDS. And I think once we've done that, even if we don't get a marker, which is a reality that we may have to face, it will still give us an answer, because it will be for the first time that this amount of whole genome sequencing would have been done on that many people, and even no answer is an answer. So we're very, very excited for what will be unraveled. Another thing that we're very proud of is EDS Echo. Now, Project Echo was launched in New Mexico for hepatitis C. The professor there was tired of people traveling all over the country to see him, making themselves much sicker in the journey, having to wait for years to see him. And we thought that sounded very, very familiar to the EDS story. We know there's not enough experts around the world globally. And we also know that there's no such thing as an EDS expert. Anyone can diagnose and treat EDS, especially how multi-systemic it is. It could be a GI specialist, a neurologist, a geneticist, a rheumatologist, and so on. So we really wanted to take this kind of tele-mentoring framework that Project Echo had built so successfully for hepatitis C. They had now rolled it out globally to lots of different disease areas. And we became the first and only one that is out there for EDS. And we kind of trailblazed in a lot of ways. So we were the first non-profit to be doing it in 2 different locations. We ran one out of London and one out of the US. We were the first ever to do an advocacy echo. You can see here how the format has expanded. We now do a VEDS EDS echo, an advocacy EDS echo, and that is just for the community of patients, because we realized that it's all well and good having health professional experts, and that's essential, but also what we need is advocates on the ground raising awareness, the right awareness, using the right terminology, being consistent with the messaging. So that was really exciting, and it was the first of its kind, and it's been a really big success. We're also really excited we have allied health professional echoes running out of the UK, the US, and Australia. Really, really well attended program. And we launched just a few months ago our first nurses EDS echo. And our target was to have 1,000 new people able to care for and diagnose EDS by 2022. And I think, it was 2021. And we are over halfway there. So we are going to reach that target, and hopefully in turn ensure that geography and wealth no longer determine your quality of life, and that you can reach an expert that you need no matter where you are. And this is a long-term project for us, and we hope it will keep growing. So our strength begins with hope. It really does. And in a time like this, it's extremely challenging. We have stepped up the amount of virtual support groups that we're offering our community. As you can only imagine, all of our in-person events for 2020 and 2021 have now gone virtual. But what this has done is enabled us to reach people we've never reached before. This summer, we had our first fully virtual summer conference. On average, between 800 and 900 at best attend those. We had 1,600 people from something like 45 different countries. We had 5 languages being translated live. Please accept my apologies for my dog barking in the background, the joys of working from home. And really, we just thought with every challenge, let's meet it with an opportunity. And although we can't meet in person, there is so much opportunity to reach so many more people. And that's what we've done. At our summer conference, we had 78% first-time attendees, which is just amazing. It just shows how many people you can reach with this virtual model. So although times are hard and they are challenging, especially for those living with rare and chronic conditions, we remain hopeful. We remain doing all that we can for our community. And I am very open to welcoming any questions that you may have, both here and also via email. You can see both the Society's contact details and mine direct. And I'm very happy to answer any questions or give you any advice that I can. Thank you very much.
Very much, Laura. That was wonderful. Both of you, fabulous presentations, despite the challenges that we've had tonight. And we're going to open it up for questions now, and Andy is going to take it away here.
Yes, I do have some. There's some really great questions coming in. We won't have time to get through all of them, but some of the most popular ones had to do with questions about specific gene interactions with the potential for finding the gene for hypermobile type EDS. And the HEDGE study sounds really promising. So I would like to just echo Laura's recommendation for people to sign up for the registry and consider that study. And it sounds like the work is very much so ongoing to try to find the most likely the genes, not a single gene that causes hypermobile type EDS. That was more of a statement. Going on to the questions, Dr. Dhar answered a little bit in the chat, but there were several questions having to do with whether EDS, hypermobility type, is a degenerative disease. If you do have degenerative joints secondary to this, is there something you can be doing to reverse that or to prevent additional wear and tear?
Yeah, so it's, like I said in the chat as well, it's usually it's not overall a degenerative condition. So I think what I usually find that people are anxious about is, you come walking into my clinic today, will I be in a wheelchair 10 years from now? And that's usually not the case. And that's why I spend a lot of time explaining sort of how physical therapy and toning of the muscles really help. Kind of to keep those joints stable as best as you can, along with sort of reducing other comorbidities. But there is increased wear and tear because the joints are loose, and just like all of us as we age do develop arthritis, there is going to be sort of sometimes early onset of arthritis because of just so much wear and tear. So try not to overextend your joints as much as you can. Most people will tell me, I don't know that I'm hyperextending, because to them, that's their normal range of motion. And so maybe looking around, seeing, if you're able to do something that most people cannot, then you're hyperextending your joints, and you should try to avoid doing that.
Thank you very much. This is a question for Laura and maybe also Shweta, Dr. Dhar. Did you guys have any advice for navigating EDS in the workplace?
I think it's very hard. I think it's definitely a global issue. People in the workplace not really offering the adaptations that should be there. But one thing I will say is that you absolutely have the right to ask for those. So chairs, how you're sitting, your posture, where your arms are lined up, having support for where you're holding the mouse and the keypad, things being at the right height for the neck. Even just sitting here like this, looking down just a slight bit, I can feel it in my neck. So I always have the monitor day-to-day working at eye level, those small tweaks, you won't believe the difference it will make, and it makes things much easier. I think temperature is another one. So I will never understand your country and air conditioning. Honestly, every time I come there, I'm always freezing, and it makes everything hurt so much more. So making sure you're warm, and if you've got maybe a hot water bottle or hand warmers, keeping your feet warm, to me that really helps pain. And it's really hard to moderate where you are with that AC. So I think those kind of tips are really important. But always remember, I say it, but I know the reality is that people do fear it. But you shouldn't fear speaking to your employee to make those adaptations, worrying about losing your job, because you absolutely have the right to ask for those things. So please know that. But I know it can be scary. But I think, asserting yourself, we've got lots of resources on our website that back up the need for those things. And like I said, we've got our helpline if you wanted to have a one-on-one chat about it.
Good. Dr. Dhar, could you comment on whether there's any contraindications for specific types of birth control in hypermobile type EDS?
So usually you want birth control that has sort of lower estrogen and more progesterone. And so because estrogen tends to relax all the ligaments, so you kind of want to have formulations that would give you less of the estrogen content in them.
Thank you very much. I have several questions about who should be on your EDS team in terms of your subspecialty care. Could you guys comment on generally who should be part of that team? What types of specialists other than genetics?
Yeah, I'm happy to answer this one. The people that should be on your team are the people that you need on your team. And I think it's really easy for you to go on to, when you're navigating EDS and HSD, you have so little, and you turn to Google and you read about all these things that could happen, and you almost think you then need to arm yourself with all of these: a neurologist, a gastroenterologist, a urologist, a geneticist, a rheumatologist, in case, because it could be. But there's such a big spectrum with EDS and HSD, and you may never have any of those issues. And sometimes, psychologically waiting for that, what could go wrong, really doesn't help as well with the day-to-day. So if and when things go wrong, then that's who you should see. And remember that, it needs to be seen through the lens of EDS, but it's very important to remember that not everything is because or down to your EDS and HSD. You could just have something else that's happened that's completely separate to that. So it's important to remember to not put everything under the same umbrella, and I think it also depends geographically where you are. So for example, in the US, you're much more likely to see a geneticist with EDS. In the UK, it's a rheumatologist. You very rarely see a geneticist. And so I think it does differ. I know most of you, I think all of you are in the US, so it is usually a geneticist. But after that, the other thing to remember is there is no such thing as an EDS specialist. It doesn't exist. All it is someone that has been willing to learn and educate themselves about the condition, and that happens across all the disciplines. So when you are symptomatic in an area, then you should seek someone out, and don't worry too much if they aren't really knowledgeable EDS, because all you have to find is someone that's willing to learn and listen and validate. And that's really all that's needed for you to get the care that you deserve.
Thank you very much. Are there any, what is the best way for someone with EDS to be able to hydrate, especially here in Texas with their love for air conditioning and hot weather?
So I think there's different sort of formulations that are available, and I think anyone is okay so long as you do have, as I said, sort of salt. Don't just drink water alone. Whether that is homemade lemonade, you put salt and lemon and whatever other sort of taste modifiers you want, or you take your Gatorade or G2, you want to be careful with the calories, because, if you are drinking a lot of Gatorade or such sort of drinks, they are rich in calories. So you kind of want to be careful with that. There are pills that you get that are just electrolyte pills that you can dissolve in water. There are salt tablets. So I think that there's no reason to kind of, say that one is superior than the other, so long as you maintain that hydration sort of during the day.
Thank you very much. There are a couple questions about ADHD or kind of trouble paying attention and this idea of brain fog in EDS and, whether those are connected and how those might be overcome.
So I'm happy to keep answering questions, but I do want to be mindful. It is 7 minutes past the hour. So I don't know, Susan, how much we want to... You're muted, I think, Susan.
Would another couple of minutes be okay? And I know Laura's about to go to sleep right now.
Yes. All right. So I'll answer that question about the ADHD. So there are, we do see that ADHD and, some of these sort of disorders are seen more often in people with EDS. And again, not knowing, particularly the hypermobile type, not knowing what the pathophysiology is, I think it's just definitely hard to explain the link. Right now, we just have sort of more statistical associations, so to speak. But that is something that we do see in people. And I think somebody just posted about fibromyalgia. It's the same thing. Now, whether it is truly, sometimes I feel maybe some people are given the wrong diagnosis of fibromyalgia, when in fact everything is sort of explained by EDS. Whereas sometimes if you don't have the features of EDS, but then you have sort of fibromyalgia, then that's fibromyalgia. But it's hard to imagine that you have both because there's just so much overlap in the different symptoms between the two.
I'm just about to share a link in the chat to a conference we held in Edinburgh that's all about ADHD, trauma, PTSD, brain fog, anxiety, depression, mindfulness, therapies, an amazing conference with some incredible experts. So that link is there. You can watch all of those talks now for free on our website. So I encourage you to look at that. And in that section of our event, you'll see conference talks on pretty much everything you can imagine associated with EDS and HSD. And we've also got languages, translations for people. I think there's some people here speak Spanish. We've got some Spanish speaking content on there as well. So have a look up there, watch away, and hopefully some of your answers will be there.
Very good. Thank you so much.
Yeah.
And I think with that, we'll stop with the questions today. We wish we could get through them all.
I know. Thank you both so much. You are really, truly amazing speakers, and you've done such a fantastic job tonight with these slight complications. So we did put a survey link in the chat, and Laura Ellis put that in there, and we'll send it to you by email as well. I also want you to know that we will have 2 upcoming webinars in the next month. The one in 2 weeks on November 24th will be on non-invasive prenatal testing. And then on December 8th, we'll be on tuberous sclerosis complex, and we'll send you that as well by email. Really, a round of applause. That was fantastic. Thank you, Dr. Dhar. Thank you, Ms. Bloom. Wonderful. Thank you all.
Thank you. Thank you. Thank you, Susan and Andy and Chris. Thanks, Laura. Bye-bye.
Good night. Thank you, Andy. Thank you, Chris.
Good night, everyone.
Bye-bye. Good night.